case-based controversies in stroke. Jan asked me to tackle this topic. Again, the obligatory disclosures, which I've given you already. I've got 4 case-based scenarios to share with you from my daily stroke practice. Two of them will focus on acute ischemic stroke. We're going to talk about clot retrieval devices, and we're going to talk about what we should be doing with blood pressure lowering. I think we have some competition here from outside. We'll then go to recurrent stroke prevention, talk about when we should be recommending endarterectomy or angioplasty and stenting, and then get into some controversies about the great statin agents, which have been very important to our survival and treatment plans. Okay, so let's look at clot retrieval devices and blood pressure management. And here's a case that I'll share with you, so let's take a look at it. Acute ischemic stroke patient. 70-year-old man, sudden onset right face and arm weakness, and some minutes later is aphasic. So right-sided weakness and aphasia, a typical combination in a stroke patient, brought to the emergency room 5.5 hours later. Past medical history, he's got the usual hypertension, high cholesterol. He's on atenolol, hydrochlorothiazide, atorvastatin. He has been taking aspirin, 1 per day. On the neurologic exam, he's got a Broca's aphasia, or so-called expressive aphasia. He's got right face and arm weakness. We do what's called an NIH stroke scale on all of these patients. It's 11, so that's a moderate neurologic impairment. Blood pressure a little high in the ER, 182/103. Not so uncommon, though, in our practices. He gets right down for an echocardiogram and EKG. They're unremarkable for any high-risk cardiac source embolism. And here's his MRI, MRA, which we got out of the emergency room. And so what you see here is, here's the MRA, and you can see that the middle cerebral artery on the right side is wide open, but on the left side here, it's cut off. So he's got a left middle cerebral artery syndrome with Broca's aphasia and right-sided weakness. And if you look at his MRI sequences, the diffusion-weighted image, or DWI, shows a large ischemic infarct within the first hours here, designated by the white area. If you look at his FLAIR image, which is also an indicator of acute ischemia, you see large infarct here with this white hazy areas. And the T2 star-weighted image, or gradient echo, shows that there's actually some blood, this dark area. So he's got a large ischemic infarct with some hemorrhage, or what we call a hemorrhagic infarction. So first question is, what do you do next in this patient with a Broca's aphasia, large infarct, and right-sided weakness? Do you give him intravenous TPA, or do you perform an emergency cerebral angiography study and then consider administering intra-arterial TPA? Do you deploy a clot retrieval device, such as the MERCI Retrieval device or the Penumbra device? Do you deploy a clot retrieve, or do you put a retrievable stent in to open up that middle cerebral artery, or do you do medical management only? So let's look at the answers here while you're thinking about it. Intravenous TPA, you're outside the window. We have now up to 4.5 hours to give intravenous TPA. He's not going to get intravenous TPA because of the time window. He's at 5.5 hours. He's beyond the time window. The infarct was also too large. Once you get greater than 1/3 of the hemisphere, you're not going to give intravenous TPA. It's contraindicated. He also has evidence of brain hemorrhage, which is going to take you out of the intravenous TPA story. So don't give him intravenous TPA. What about intra-arterial TPA? Well, you have up to 6 hours. It's unlikely that once he hits the ED at 5.5 hours that you're going to get everything done in a half hour and treat him, because you have diagnostic studies that he had, so he would miss that window. Again, the infarct's too large, and there's brain hemorrhage. Not a good candidate for intra-arterial TPA. What about a clot retrieval device to try to open up that middle cerebral artery and drag the clot out of it? Well, again, horse is likely out of the barn. It's a large infarct. You're not going to make him any better. So let's flip the question a bit. What if the neurologic deficit was more minor and the MRI abnormality was more minor? What if you had this? in this patient. You've got some aphasia, you've got a moderate neurologic deficit, and now you have some middle cerebral artery stenosis, but the artery is still open, so there's some blockage here. There may be some clot. You've got a much smaller diffusion-weighted abnormality in white here. You don't see that hemorrhagic component, and on the FLAIR image you can see this white area here, and over here. This haziness is part of the recent infarction. So what do you do in this case? We want to save the brain. Now we know that some of those areas are going to be dead or core infarct, such as in red. Some of the areas are probably hypoperfused, like here in yellow, and some of them are at risk of infarcting, and some of them are going to remain viable. So we can map out the brain blood flow, and we can map out the perfusion to the brain and find that the brain is salvageable. So maybe we should go and get that clot. Here's a clot retrieval device. This is called the MERCI. It's FDA cleared for use, and you can see the size of the clot that we pulled out in one of our patients. And if you want to get some idea of that clot that looms large in the mind of the clinician that's wreaking havoc in the brain, sometimes they're long and they're centimeters long, but oftentimes a small clot that's millimeters in size here can just take out your whole hemisphere of your brain. So the clots can be small at times, but they are retrievable. And here's another one of the devices. This is the Penumbral System. And the question is, in this patient with the milder stroke abnormality for acute ischemia on the MRI, should we be tempted to use this clot retrieval device? How many of you have had your patients had a clot removed from one of the major cerebral arteries during acute ischemic stroke? Anybody? Yeah, okay, so there's a couple of people. You've used the clot retrieval devices. You probably have aggressive interventionalists at your sites, and every time that they take the saran wrap off that catheter and insert it, it's about $25,000 that gets billed out for that. So it's a very interesting procedure. The hospital administrators love it because it brings in lots of dough. That's not the question, though, that I'm asking. The question I'm asking, is it indicated? Should we be doing it? I've already told you that the FDA cleared these devices. I didn't say they approved it. I said they cleared it. Clearance means that the device does what it says it's going to do, and in this case takes the clot out, and it's relatively safe. Approval is a much more stringent process. You know that we get drugs are approved or pharmaceuticals are approved by the FDA. It usually means they've gone through 2 rigorous large-scale clinical trials. These studies don't have to have those 2 large, rigorous clinical trials for devices. They can just have a study or 2 that uses historical controls sometimes. And so that is a whole different process. So anyway, here's something that came out in the neurology literature by Tom Tomczyk and colleagues. Tom is an interventional neuroradiologist, University of Cincinnati. And Tom first authored this article about equipoise among recanalization strategies, and that we really don't know for sure if intravenous TPA and these intra-arterial reperfusion therapies to remove clots and lyse them, which is better. We might be able to just do intravenous TPA and never have to bother with this $25,000 entry into the brain. And so the IV therapies, you can give them pretty quickly because you don't have to do an angiogram and position the catheters and all that. However, we're not sure about the rates of recanalization with the clot retrieval devices in relation to associated improvement of outcomes. So if you open an artery, theoretically, you're going to recanalize and reperfuse. But does that opening of the artery, recanalization, really lead to reperfusion or not, and better functional outcome? That's the question that we need to answer, and that's where the equipoise or uncertainty is. And here's an analysis of neurothrombectomy using these devices to remove these clots. And the reason why I'm showing you this is because the evidence is rather low level. We don't have high level evidence. These are case series and reports for the most part. And although these devices are very intriguing and sexy and we'd like to use them, there is not adequate power to show equivalency or non-inferiority of these devices with our standard medical therapy with intravenous TPA. So we're doing them. The use of these devices is growing, but the problem is that we really don't know from high-level data if they're working in an efficacious way or not. Recanalization rates, this is the MERCI device, this is the Penumbral System, they're fairly high. You can see these ranges are fairly high. They do come at a price. There can be hemorrhages that occur in the brain. There can be vessel perforations or dissections, which can occur in the brain, which of course are not good. And if you look at what happens to these patients, and this is where I'd like to pique your attention about these devices, this is from the National Inpatient Sample Survey from a couple of years ago of almost 4,000 patients who received endovascular clot retrieval devices. And what I want you to see here is that the percent who died with these catheter procedures and the percent who ended up in long-term care facilities, meaning they're debilitated, if you add up the 51.3 and the 24.3%, you're almost at 75%. So this doesn't look so good. So although we're doing them and we have some triumphs, if you look at the group overall, almost 4,000 people in the US who have these procedures, about 75% of them end up dead or in long-term care facilities. So are we really improving the situation with these devices or not? We need more high-level studies to show whether it works or not. Obviously, if you're older, the in-hospital death and the transfer to long-term care facilities is a lot higher than if you're younger. Okay, so summation to this question, should we be tempted to use these devices? I think the bottom line is we need more evidence, and we need to support ongoing clinical trials such as the DIAS trial and the IMS-3, which are looking at medical and neurothrombectomy devices. Here's a second question. How should we manage the blood pressure in this case? The patient came in, as I showed you, with a blood pressure of 182/103. Should we raise that blood pressure to try to increase perfusion? Should we lower it? Should we stop the antihypertensive drugs, leave the blood pressure alone, or monitor intracranial pressure in the case? So this is a very specific question that the neurovascular folks and the neurocritical care folks are always addressing. You may be called from the emergency room. This patient has this blood pressure. They're asking you. You may be in your office or on call at night. What should we do, doc, with this pressure? Well, let's look at the data. This is to remind you that when you have a hypertension, the autoregulatory curve for the brain is shifted over here to the right. So theoretically, if you lower blood pressure too much, you're going to fall off the autoregulatory curve, you're going to extend the ischemic infarct. In the ischemic infarct territory, there's a linear relationship. As the blood pressure goes up, the cerebral blood flow goes up, so you got to be careful because that area doesn't autoregulate, but for that tissue that's already dead in the infarct, you're not going to do anything more to help it. But it's that penumbra or shadow zone that I showed you of salvageable tissue that you want to save and not let fall off this particular curve either. So the pros of lowering blood pressure are that you might reduce edema formation in the brain, lessen the risk of a hemorrhagic infarction or transformation. You begin early recurrent stroke prevention therapy by lowering blood pressure. And if there are compelling indications such as renal failure, pulmonary edema, myocardial infarction, you'd like to keep the pressure low so the afterload is less on the heart. The con of the argument is that aggressive medical therapy of lowering blood pressure may lead to worsening by reducing the perfusion pressure. So these are the pros and cons of lowering blood pressure. Here's what our guidelines tell us from the American Heart Association for acute ischemic stroke. Basically, we have a data deficiency here, so we have to do something that is by consensus, because there's not enough high-level studies available. And so we believe that lowering the blood pressure by about 15 to 20% within the first day is reasonable, and it's usually safe, and that after one day, if you feel that the patient's collateral circulation based on your imaging studies is stable enough, you can start gently lowering the blood pressure. So you start aiming for your chronic blood pressure lowering targets to reduce recurrent stroke prevention. And again, lowering blood pressure chronically is a very powerful means to reduce recurrent stroke. Let's look at a couple of studies. One was the Continue or Stop Post-Stroke Antihypertensive Collaborative Study, or COSACS. And this was conducted in the United Kingdom. And the question was, should we continue or stop pre-existent antihypertensives? And that's how they come to the emergency room. Most of our patients have high blood pressure and they're on antihypertensives. Should I, as a clinician, keep that blood pressure medicine going, or should I stop it? These guys had a very practical question to ask in the United Kingdom, and they ran the study for 2 weeks of either continuing or stopping medicine. Then they looked at outcomes at 2 weeks and 6 months. The outcomes were death or dependency in the study. And here's what happened. The primary endpoint was reached in 72 patients out of 763 who continued the blood pressure lowering medicine, and 82 in the group that stopped the blood pressure lowering medicine. And you'll see here that the relative risk was no different statistically. So it did not matter in this particular case. The problem was they were having trouble recruiting patients, and the study ended up being underpowered. So they said, we need some more data to add to this. Well, here's some more data for you. This is the Scandinavian Candesartan Acute Stroke Trial, or what's called SCAST. And what they did here was they compared addition of candesartan or placebo for 7 days with dose increases during those 7 days in patients who came in with acute ischemic or hemorrhagic stroke and elevated blood pressure within 30 hours of the stroke. It was done at numerous centers in Europe, 146 centers in 9 countries. And they looked at key outcomes at 6 months after stroke onset, and they had over 2,000 people who were randomized to either lower the blood pressure or stay on their medicine and get a placebo. And guess what? The people on candesartan had a 5/2 drop in blood pressure. They added another blood pressure lowering medicine, and guess what? It works. You can lower the blood pressure. However, the primary outcome endpoint that they looked at 6 months of vascular death, myocardial infarction, or stroke, again, did not differ between the treatment groups. This was a non-statistically significant reduction, or increase in this case, based on the hazard ratio. However, what was of interest was that the functional outcomes, that is the disability outcomes, showed that the people who got the candesartan treatment had poor outcomes. So although there was no statistically significant reduction of stroke, MI, and vascular death, neurologically they did worse if they were treated. Well, life is just not simple, and Although this study did not support blood pressure lowering in acute stroke, a second study that does not support it, the current evidence still, we believe, is in clinical equipoise. There's a couple more studies out there that I've listed here that are going to probably more definitively answer the question. I wrote an editorial in Lancet Neurology about all this stuff. I did it right before my daughter got married, so I was a little bit distracted. I think I got most of it right, but then we finally married her. The good news was she paid for the wedding. My wife and I were delighted. There is a God up there based upon her favor that she returned us. So anyway, we're not sure if you should lower the blood pressure, leave it alone, and what to do with it. Right now, we're usually, in my practice, keeping the patients on their medicines. We reduce it by 15 to 20% if we think it's too high. And then after about a day or more, we start recurrent stroke prevention and start getting the pressures down. We're aiming for a JNC7 of less than 140/90 eventually. But early on, we're not upset about letting the blood pressure stay higher for the first week or so. You're probably not going to hurt your patient. There's a compelling indication to bring it down. Hypertensive encephalopathy, acute MI, aortic aneurysm, whatever it is, you can bring it down. And after the first day, it seems to be safer to do that. So here's another question. I call this the bonus question. Which of the following best characterizes atenolol in blood pressure management and stroke prevention? Now, I'm sure that a lot of you are using atenolol in your practice. Why? It's cheap. The managed care systems love it, don't they? Because you have a generic form. So you're probably using a lot of atenolol. The question is it a first-tier option for initial therapy for blood pressure lowering for stroke prevention? Is it a second-tier option? Is it a third-tier option? Is it a drug associated with variability of blood pressure and a record of failure to prevent strokes? Is it a drug associated with little variability of blood pressure and a record of success in prevention of stroke? So think about that for a moment. And here's the answer. Atenolol is associated with blood pressure variability, meaning there's spikes in blood pressure, we believe, periodically during the day, and actually has a poor track record of success. Now, there's a lot of reasons why. Some believe that the beta blockers aren't good for blood pressure variability. Some believe that atenolol was not dosed properly in the studies. It's a BID drug, and it was only given once a day. However, in the United Kingdom, they've pretty much banned its use as a first or second line agent, so that although it reduces mean blood pressure spikes or variability may be noted and portend poor stroke reduction rates, so it's generally discouraged for use. There are better beta blockers. Okay, let's get into endarterectomy and the statin story, and we'll wrap up here. This is another controversy in stroke that you may be faced with in your practice. So here's a 70-year-old woman, has transient left arm and leg numbness for 10 minutes. She has all the risk factors: diabetes, hypertension, hypercholesterolemia, as you'd expect. She also has mild memory impairment. She's on rosiglitazone. How many of you are still using rosiglitazone? Probably not many, because the FDA requires you to fill out a REMS form to justify its use because of the controversy with this drug. She's also on telmisartan, the ARB. She's on simvastatin, the cholesterol-lowering agent, and donepezil. Somebody's trying to goose up her memory function here. Neurologic exam, she had a little memory problem, otherwise unremarkable. CT head atrophy. MRA, high-grade right carotid artery stenosis. She goes on to have a cerebral angiogram. It verifies the high-grade carotid stenosis. And on MRI head, she has cerebral microbleeds. Now, a lot of people aren't familiar with cerebral microbleeds, what the significance is. Does anybody know much about the microbleeds? We're going to go into that in a moment. Okay. So here's the picture again: high-grade carotid stenosis on conventional cerebral angiography in a TIA patient. And here are the microbleeds, my friends. This is something new and important. So you see all these black little dots here? These are cerebral microbleeds. This was probably a little larger bleed, and these microbleeds are detected on gradient echo or GRE MRI scans. They're also seen on what's called susceptibility weighted images from MRI or SWI, or they're seen in T2 star weighted image. All of these techniques mean the same thing. And when you see these microbleeds in the cerebral cortex, all these black little holes or dots, that means you probably have cerebral amyloid angiopathy. I said she had some memory loss. Cerebral amyloid angiopathy appears to be responsible for these microbleeds in the cortex. If they're deep in the brain and the basal ganglion and the brainstem, they're probably related to hypertension. But these folks, when you see these, they are headed for Alzheimer's disease if you see a lot of these, okay? The other problem is it ain't good to have little bleeds in your brain, and we have a problem because most of our older patients need what? Antithrombotic therapy. They're either going to go on anticoagulants or they're going to go on antiplatelet agents. So this poses a big problem for us. And a lot of people believe that if you have 5 or more of these little spots on your brain, that you are at risk to have a major brain hemorrhage or cerebral macrobleed. And so beware. We haven't worked all of this out, but what I can tell you is that if you have to treat a patient who has a lot of these microbleeds of the brain with an antiplatelet agent or an anticoagulant, you best keep that blood pressure down, because that may be one of the better ways to try to prevent these microbleeds from becoming a big brain hemorrhage or macrobleed. Okay, so which of the following is the best strategy to manage high-grade symptomatic carotid stenosis? She has high-grade stenosis, it's over 70%. Do you do medical management alone? Do you ask your interventionalist to come in and do an angioplasty and stent? Do you get your vascular or neurosurgeon to do a carotid endarterectomy? Do you do medical management plus angioplasty and stenting, medical management plus carotid endarterectomy? So what's the answer? Anybody have any thoughts? Number 5 is a winner here. Anybody else? Okay, you don't trust your angioplasty and stenting people, I see. Well, you may have good reason not to. We'll show you the data. Okay, so here's the AHA guidelines from 2011 for recurrent stroke prevention. We favor carotid endarterectomy when there's 70 to 99% stenosis. We've been using carotid artery stenting as an alternative if they can't have an endarterectomy. Look, folks, carotid endarterectomy has been well-tested, well-traveled since the 1950s, some 60 years of experience. If you have a good operator, they have an endarterectomy, they have an 8 to 10 year warranty. Okay, that endarterectomy can last up to 8 to 10 years after they've done it. I ask you, my friends, what American-made car will give you 8 to 10 year warranty? Come on, come on, who's got it? No one can say that they've got it. We just don't get that kind of warranty like you do with endarterectomy, do you? Okay, so some people can't have the endarterectomy. Too much medical comorbidity. They may have a high carotid bifurcation. They may have radiation and scarring in the neck. They may have had an endarterectomy before and the surgeon doesn't want to go back in because they scarred a lot in the neck. So there are indications for it, but I will tell you that if you look at all the European data, the ICSS study, if you look at the SPACE and EVA 3S studies, all of the European data seems to indicate that endarterectomy is better. Of course, people on this side of the ocean say, oh, they had rookies doing the angioplasties and stents. It wasn't fair. If you look at the US study, which is the CREST trial recently published in God's Journal, you will find that for people 69 and less, it appears that the angioplasty and stent was slightly better than endarterectomy. For people 70 and above, endarterectomy rules. And so as the atheroma gets more complicated with age and there's more tortuosity of vessels, it appears a direct approach with endarterectomy in older folks is better. I happen to be a big believer in carotid endarterectomy. I like that up to 8 to 10 year warranty that we can offer you as part of the package. Angioplasty and stenting doesn't have the data yet to follow enough people that long to know for sure. Okay, so I've already gone over who you might do angioplasty and stenting and who you should do endarterectomy in. And the question here is, what's the significance of cerebral microbleeds in this patient? I've already answered it. It's all of the above. It's a precursor of cerebral macrobleeds, or large intracranial hemorrhages. It's a precursor to Alzheimer's disease. And it's an amyloid, cerebral amyloid-based angiopathy. And please remember, the cerebral amyloid-based angiopathy will not be diagnosed by a rectal or tongue biopsy. For systemic amyloid, they have nothing to do with each other. Too many of our medical students, when I ask them how are you going to make the diagnosis of cerebral amyloid angiopathy, tell me I'm doing a tongue or a rectal biopsy or peripheral nerve biopsy. Cerebral amyloid angiopathy, specific to the brain, has nothing to do with systemic amyloid. Okay, so here is the birefringent path specimen here of the cerebral amyloid angiopathy in the small and medium-sized arteries of the brain, a precursor of cortical hemorrhages. And the answer to question 5 in summation, cortically based cerebral microbleeds thought to be a precursor of macrobleeds related to cerebral amyloid angiopathy and Alzheimer's disease. Finally, the last question, if this patient had a history of a lobar brain hemorrhage, meaning a macro hemorrhage, intracranial hemorrhage, would you feel comfortable administering a statin agent or an oral anticoagulant if there was atrial fibrillation? So let's focus on the statin part of the question. Yes, no, don't know, depends on overall cardiac risk or risk-benefit ratio. So we have a lot of patients that need statin agents, especially as they age. And the question is, if you've had a past brain hemorrhage, should you be administering statins? This comes up in my practice all the time. So what's the concern about statins and intracranial bleeding? It's right here. If you look at the Sparkle trial, where atorvastatin was given to patients for recurrent stroke prevention, what they found is that there was an excess of brain hemorrhages in the follow-up in the atorvastatin-treated group versus the placebo patients. And so you see that excess with atorvastatin here based on the odds ratio, and it was primarily in men. I don't think we'll be able to change their sex readily in time to reduce that risk, to make them women. Age, with each 10-year increment, the risk of hemorrhage went up, and then poorly controlled blood pressure here, stage 1 and 2 hypertension in the old one of the old JNC6 or the old JNC classification. So the point is that atorvastatin may be associated with risk of brain hemorrhage in these patients. I will call your attention to an article in circulation which just came out online from Hackham and Spence of Canada, where they looked at every conceivable study about statins and brain hemorrhage, and they found no association. So there are still a couple of clinical trials that are showing this, but overall, most of the studies are not showing this association. But my message to you is that if you see those microhemorrhages or there's a history of lobar hemorrhage especially, I would still be aware of these statins, and I would try to get that blood pressure down, because that's the most potent way to prevent a brain macrohemorrhage. So here's a nice study on decision analysis, which of course is always mind-boggling with all the assumptions that they make in these decision analysis studies. This came from our friends at the Massachusetts General Hospital, Westover and colleagues. What they basically showed was that if you have a history of lobar hemorrhage, you better be careful with administering statins, because it looks like they're the ones who are going to go on to have another lobar brain hemorrhage. Everybody else, it appears reasonable to use the statins in relation to risk of brain hemorrhage, but if you've already had a lobar hemorrhage, you better have a real high-risk benefit ratio to consider using them, and that would probably be our coronary patients who are running on a thread of coronary.